just sitting at the end of the foot, and there's so many different types of operations. There's operations on tendons, nerves, and ligaments, bones, joints, muscles, you name it. It's varied. As a consultant orthopedic surgeon for like 10 years, at no point, and I was doing 2-3 lists a week, it was always different. Anything from ankle replacements to ankle fusions to Achilles tendon surgery, Achilles tendon repair, gastric releases, Morton's neuroma, tarsal tunnel syndrome, midfoot arthritis, keyhole surgery in the ankle, cartilage repair, you name it. It's like there's literally like 100 different operations you can do.
Welcome to Beyond the Pain, the podcast that explores what it really takes to break free from chronic pain and reclaim your life. I'm your host, Leigh Brandon, and someone who's spent over 2 decades helping people get to the root cause of pain that no one else could explain. Whether you're dealing with long-term back issues, joint pain, nerve discomfort, or mysterious symptoms that just won't go away, this show is here to help you go deeper. Because beyond the pain, there's clarity, strength, and power waiting for you. Each week, we'll uncover the physical, emotional, biochemical, and energetic causes of pain and how to transform them. Let's dive deep into this week's episode. Today, I'm joined by someone who brings a rare blend of surgical expertise, honesty, and a deeply human perspective on healing. Doc Malik, an orthopaedic surgeon whose story begins in a working-class community in Glasgow and unfolds into a career shaped by curiosity, frustration with the medical system, and a passion for truly understanding the human body. In this conversation, we explore the disillusionment that he had with the National Health Service, why he believes surgery is often misunderstood, and the importance of looking at the whole body, not just the foot or ankle, when it comes to helping someone move out of pain. We also get into the emotional side of healing, how alignment influences everything from joint mechanics to mood, why footwear choices can either support or sabotage your health, and how the mind can shape the way physical pain shows up in your body. It's a fascinating deep dive into the interconnectedness of physical health, emotional well-being, and the small everyday choices like the shoes you wear can make such a big difference. So let's get into it.
Yeah, I should stop asking you questions. I should remember that this is your podcast. So congratulations on your new podcast, 3-month-old podcast.
Thank you. And thank you for naming it for me.
Yeah, did I name it?
I did.
I suggested something. Did
you suggested the name, and I said that's a good idea, and I went with it.
Oh, right. You actually picked the name that I suggested. Oh, that's amazing.
I did. So you're the first person that's been on my show that actually named it.
Hey. Well, I'll be the only person unless someone else came up with the exact same name.
No. Well, interestingly, there is a YouTube channel with the same name, but I didn't know that. But they don't have the podcast name. I have the podcast name. They've just got a YouTube channel with the same name.
Yeah, because you were talking about rebranding and changing your podcast name, and I thought it was too focused and too niche. And I thought, as a Czech practitioner and with your knowledge, there's so much you can talk about, but you can use pain as like a central theme, but, so much is wrapped around pain that you could then explore and talk about, if that makes sense.
Yeah, definitely. But anyway, it's great to have you back on in its new guise. I want to give the audience a little bit of an understanding as to why I've asked you back on. And really, I was watching one of your episodes on your podcast, which is my favorite podcast, by the way. So Doc Malik,
you say that
Honest Health.
You say that to all your guests.
Well, that's true. No, I don't. But no, to tell you the truth, so my morning ritual is that I wake up, I have my cold shower, I make a cup of herbal tea, and as that's cooling down, I do joint mobilizations, I do stretches for about 20, 30 minutes every day. Whilst I'm doing those, I've got Doc Malik Honest Health podcast on every morning for 20, 30 minutes. That's my morning ritual. And that gets me started for the day. And for those who haven't tuned in to Doc Malik's podcast, I highly recommend you do. A, for great health advice, but also if you want to really know what's going on in the world, right? I think your podcast is one of the best sources for knowing the truth as to what's really going on, not the nonsense that we hear on TV and so-called alternative media. You really get to the heart of the matters. And I'd highly recommend, if you want to know what's really going on in the world, to check out Doc Malik's podcast as well. So I was watching an episode of your podcast a while ago, not that long ago, actually. And you was interviewing a lady, but she wasn't really coming forth with a lot of stuff. And you started talking about your career and your career as an orthopedic surgeon, and your passion for that work that you used to do really came across. And I just thought, I need to get you on to share not just your passion, but your knowledge, because, you was in that field for decades, right?
Yeah.
So, and also because there's an overlap between what you was doing and what I do in my work, because, the foot and ankle is a part of the human body, right? It's not separate. As some orthopedic surgeons might think their, area of expertise is separate from the rest of the body. And I just thought it'd be great, A, to get your view on foot and ankle conditions, and also to have a dialogue rather than it just be an interview. We can discuss things from our own individual aspect. So what I would like to do to start things off is, I know obviously you've been on this podcast before, and you shared a lot about your history and what you went through in the last few years, and why you're not an orthopedic surgeon anymore. But what I think would be good for the audience, especially those who haven't listened to the first episode, is really for you to share with the audience, your journey from, growing up in Glasgow, going to medical school, becoming an orthopedic surgeon, and also, apart from your foot fetish, how did you end up becoming a foot and ankle surgeon?
Oh, man.
The foot fetish thing was a joke, by the way, if anyone's listening.
Yeah, I'm not into feet that way. Not into that. Well, listen, thanks so much for your kind words. Really appreciate it. Look, very quick. Born in Glasgow, 1975. Very poor working class area called Govan. And then, lifted myself up with, along with my family. My dad worked very hard in his various businesses, from market trader to shoe shop to kebab shop to nursing home. So yeah, he worked, and he had lots of jobs, and I had lots of jobs as well. Bowling alleys and fish and chip shops, and working in my dad's shops and House of Fraser and God knows what else. I was even a phlebotomist as well. Anyway, so become a surgeon, come down to London, become a consultant. Living the dream, very hard, but got there, and then left the NHS because I was quite disillusioned with it. I realized that it was not what I thought it was. And I was brought up in a cult, and having left that cult, you get to start seeing all the cults around you. The problem is people who are in a cult can see all the cults except the one they're in. So now, now I see the cult that is the NHS. It's very abusive. It's actually a very abusive relationship. And everybody that's in that cult is trauma bonded and terrified of leaving the cult. But anyway, I left it because I was so disappointed in it. And my dad was dying of cancer. That's what spurred me on. And also, he helped me, just look at myself. I remember one day he was saying, son, what is going on? He was dying of cancer. He was sitting on the sofa. I'd come home at 10 o'clock at night, got a plate of food, heated it up. And he's like, what are you doing here? Eating dinner now at this time? You left the house at 6:30 before your wife and kids woke up. You came home just before 10 and your wife and kids are asleep. And you work like this 6 days a week. You're fat, overweight, unhealthy. You look awful. son, take it from me. I'm dying. This isn't what life is about. Like, what is it? You want to be famous? You want to be a big man? You want to have a lot of money? Yeah, is that what you want? And it just stopped me in my tracks. I'm lying there in bed all night just thinking about what he said. And I'm like, why am I doing this? Like, you just get on this conveyor belt and it just whips you along, without, you feel like you got no control. You just have to keep running on this hamster wheel. Anyway, so that's when I started turning my health around. My wife and we discovered intermittent fasting and then optimizing sleep. And then as I started losing weight and getting a little bit healthier, when you start seeing the improvements, you want to keep chasing the improvements. So now you're like, oh, I don't want to drink tap water anymore. I don't want seed oils in the house anymore. I don't want anything with fructose corn syrup. I don't want fluoride in my toothpaste. You just you started, and my wife was always a couple of steps behind me. And initially she would always be like, what the hell? Are you crazy? Like, what are you talking about? And then with a lot of effort, got her to see and realize, and then she would come on board. What was interesting was it was always the same cycle. Always, it still is actually. I still have to win her over. She doesn't just accept what I say. It's like after all this time, it's not like, that's interesting. Oh wow, there's still that resistance. Like, fine, I guess that's all right. But anyway, so we turn our health around, and then I start applying that in my clinical practice, and the NHS didn't like it, and I didn't like the NHS, couldn't practice the way I wanted to, so I left the NHS, thought I'd be free in the private sector, but that's the same machinery. It's just different way of extracting your money and giving it to big pharma and the medical industrial complex. That's all it is. It's the same medicine you get, whether it's in the NHS or private, because it's all regulated by the same medical regulator, the guidelines, the protocol, the NICE Institute, the Royal Colleges. So the reality is it's not that different, really. Anyway, then COVID hit, and I was locked out of my workplace because I'm self-employed private hospital, so I can't have furlough, got no money. And then it was like, wow, this is awful. What are we doing here? My mental health definitely suffered. It was very isolating. I didn't know anybody then. I literally had a handful of friends in the hospital system, and they were loving it. They were out having barbecues, talking about how they're getting paid to just stay at home and have fun. And I'm like, well, I'm not being paid to stay at home. I'm kind of jealous. But they didn't really care. They didn't care about their waiting list or their patients, which I found very uncomfortable. It was just like, yeah, we're having a lot of fun. And I was like, what are the hospitals like? They were like, oh, dead quiet. Nothing's happening. I was like, what? So then I started looking more and more into things, and let's just say one rabbit hole after another. And then I think I was just getting really upset about the mandates and the vaccines. And then I started seeing all these harms. And then I did a video about one of these, there's something wrong with these jabs. Like, there's a problem here. We need to maybe stop them and investigate them. And the private hospitals didn't like that. And I wrote about that recently in my Substack, and I've published their letters and I've shown what was going on. And anyway, it all culminated in them kicking me out of the private hospitals, because the problem is, as a self-employed doctor, I don't have a contract with them. I have practicing privileges, which is what it is. It's a privilege, and they can remove that as they like, which they did. They went, what, get lost. So suddenly I had nowhere to work, and a surgeon without an operating theatre is pretty useless. It's like a captain without a boat. It's like, good for you, buddy. Like, what are you going to do with that? So it was a bit upsetting, I'll be honest with you, for about a month. I was kind of like heading towards wanting to get out of the system anyway. I had set up my podcast as a hobby 6 months earlier, and I was really enjoying it. It was like fun. I was sitting in my clinic room and I couldn't wait to get to my podcast and interview someone and talk to them. That to me was the highlight of my week, not operating and blah blah. My passion for medicine was like just leaving me. I didn't have much respect for my colleagues. I'll be honest with you, I was just, if there's no respect, there's no love. And I'd lost respect. So if there's no respect, there's no love. So I was falling out of love with the medical profession. I was just like, this is just BS, man.
Mm.
Like, it's all platitudes, it's all fake, phony words. First, do no harm, and patient first. It's all bullshit. No, it's not. It's first, do no harm to my medical license and registration. First, do no harm to my mortgage, salary, career, reputation, big car, big house, fancy holidays, that kind of stuff. So and once you see it, it's very difficult to unsee it. And I felt like a prior. I remember the last foot and ankle conference I went to. I was just walking around this convention center in Liverpool, just felt like a leper. No one wanted to be associated with me because I'm talking about things on my X account. I've now got my podcast, and people just thought I was a nut job. People thought I was crazy. And if they associated with me, they might catch what I've got. So anyway, I was feeling quite lonely amongst doctors. Anyway, so in the end, when the hospitals kicked me out, there was one hospital that still kept me on, but they were the one that actually instigated all the trouble for me. So it was not like a friendly place. The place that actually started everything off and all the bullying is the place that I meant to now develop my practice. I did not feel welcome. And I left, and I had to make a decision. And by this point, I'd talked to quite a lot of doctors around the world on my podcast, and I saw it was the same playbook. Doesn't matter if you're in Zimbabwe or South Africa or Australia, New Zealand, America, Canada, Britain, Germany, Switzerland. It was anonymous complaints, suspensions, investigations, court cases, tribunals, years of pain and agony, hemorrhaging your cash, lawyers that are actually working for the other side. And if you're lucky, you might lift the suspension, but 99% chances that you're going to be indefinitely suspended or struck off and disgraced. So I looked at that and thought, fuck this shit. And by this point, I really felt that GMC, rather than being this professional body that there's to respect doctors and protect patients and look after doctors, I felt it to be something really dark and sinister. And it was like, now my license and registration, rather than being, something to be proud of, I'm a licensed registered doctor, blah, blah, now it's like a noose around my neck. So now I'm like, yeah, I want to get this off of my neck as quickly as possible. So I wrote to them, but just under 3 years ago, and said, I want to deregister and delicense. And they're like, are you sure? I was like, yes. And they went, okay. And I was like, and then they went, you're now no longer registered and you're delicensed. And I was like, and it felt like a weight had lifted off my shoulders. And then it was like, right, I've been in 4th gear. Now I'm going to go into 5th gear and, put my foot on the pedal, and off I went. And it was quite liberating because I could then just speak on my podcast without any lingering concerns like, oh, do I need to be careful? Like, now I just speak my mind. And can I tell you something? It's so good for your soul. Like, just being able to say what you want to say, it's nice. It's really nice.
Yeah.
That's it. Is that okay? Is that?
Yeah. I want to roll back a little bit because I really want to get to focus on foot and ankle as well. What was your inspiration to go to medical school, and how did that lead to orthopedic surgery, and how did that end up with foot and ankle surgery?
So basically, do you know what? I remember being in high school and thinking, what am I going to do? And I was just like, but I love surgery. I was watching all these casualties and ERs and all that kind of stuff. And I loved the fact they could make such a difference in someone's life so quickly and so easily. And I was fascinated by anatomy. I remember dissecting a frog and I was like, wow. Because you know what? Up until that point, you're like, what's inside us? Like, I can see out, I can hear, I can taste, I can feel my tummy. What is actually how do we work? And some people love to take apart a radio and learn about electronics and, you know, transistors and all that kind of stuff, or they want to know how a car works or whatever. You know what I mean? You know, you dismantle something to see what the inside is like. I had that kind of fascination with the human body. I was like, what the frack is inside? So I remember, like, you know, when going to the fishmongers and when they would, you know, slit it open and take the innards out, I'd be like looking at it like, whoa. And I remember like being in Pakistan as a kid, and during a religious festival, Eid, they sacrifice a goat. And I remember watching it. I was only like 7 or something. And again, I was like, fascinating. All these things were coming out, all these intestines and liver and spleen. It's like, what does that do? What is that? You know, so I had this fascination with anatomy and the body. And I think yeah, I think it was a no-brainer. Like, my dad was a businessman, and he kept telling me, like, you need to be a businessman. You should not work for someone else. You should work for yourself. And such wise words that fell totally on deaf ears, because all I saw was my dad work ridiculous hours. I remember being very poor, life being very hard, and I'd be like, why do you want to do why do you want to be this? Like, and all the other kids in their class who, you know, whose parents were lawyers or accountants or dentists, or, you know, they had like nice comfortable lives, they had nice clothes, they didn't have hand-me-downs, they didn't have holes in their blazers. I was like, man, being a businessman sucks. But, you know, that's the attitude of a kid. You know, that was my as a little kid. So I didn't want to be a businessman. And I was like, well, what do I want? I don't want to be an accountant. I don't want to be a lawyer. It's like, doctor's cool, man. Okay, it doesn't pay as much as these other people, but it's not just about money. I mean, you're going to be comfortable, but it's fun. It's like, it's just, so that's why I went to med school. And it was so much fun. And it was exactly what I thought it'd be. Anatomy, I loved dissection, physiology, all that kind of stuff. But I didn't like medicine. So you go in the wards and you're just going around these ward rounds, and they're just giving 5 milligrams or 2.5 milligrams or 1.25 milligrams or whatever. And it was just like, what is this? Like, just giving pills, and, oh, they've got a side effect, so let's give a pill for the side effect. Oh, we don't know why this condition happens. It's idiopathic, it's autoimmune. What is autoimmune? We don't know. The body just attacks itself. Why does the body attack itself? We don't know. Everything was, we don't know. It's, you know, and I was just like, well, this is just bullshit. and then it was like, then I did my surgery attachment. It was like, this is broken, we're going to fix it. I was like, great. I love that. I love it. This shouldn't be here. We're going to cut it out and fix it. There's pus here. We're going to drain it and get rid of the infection. I was like, yes, this is what I like. There's a problem. You can do something about it, and you fix it or you cure it. Like, ta-da! Like, there was no pill pushing or anything like that. And I didn't actually like orthopedics, because my medical student attachment, well, I was like the one guy in a group of girls, and the orthopod who was teaching and training us would just use me to humiliate me and make jokes. I think really just to impress the girls, because they were all giggling away at my expense. And I just thought, what a dick. If these are what orthopedic surgeons are like, I ain't having anything to do with it. So I wanted to be a general surgeon, because the guys that I worked with in general surgery were pretty cool. And I did my work experience with a professor in ENT surgery, and that was like my first exposure to surgery. I was like a 16-year-old scrubbed up, and it was fascinating. So I was like, I always wanted to be a surgeon, but so I was thought general surgeon. And then when I graduated, I was meant to look for jobs, house jobs. I couldn't get onto a professorial surgical job. All the jobs for the professors in surgery, and there were several in Glasgow, were all taken up. And you really wanted to work for a professor, because if you worked for a professor, you were almost guaranteed a slot in the surgical rotation. And I was like, damn it, no professor wants me, damn it. And then I saw that there was a position for a professor in orthopedic surgery. And I was like, oh, he's a professor in surgery. I mean, it's not general surgery, but it's a professor, and if I work for him, maybe he'll get me on the rotation. So I went with my CV, and I went to speak to him, and he was like, oh, and you know, why do you want to be an orthopedic surgeon? And I was like, actually, I don't. And he was like, what? I was like, I want to be a general surgeon, but all the professorial jobs in general surgery are gone. So I'm hoping if I do a really good job working with you, you know, you'll put in a good reference, and I'll get onto the surgical rotation. And the guy just he just started laughing. He's like, "Oh my God, so like you don't even want to do orthopedics?" I was like, "No." He goes, "Okay, let's make a deal. You work for me. You come to theatre every week, and you do a great job, and I'm gonna, support your application for the surgical rotation, but I'm gonna turn you into an orthopod." And in my head, I just nodded and smiled. In my head, I was like, "Yeah, not happening." Yeah, well, it happened. So that's why I became an orthopod. And then it was just so much fun. The people I was working with was so much fun, and I loved broken hips, fixing broken hips, broken wrist, fixing broken wrist, things. And it wasn't like you had to fix everything. You appreciated that a lot of things could be fixed by the body. It was only in extreme circumstances. So I just liked that. It was just, it was either broken or it wasn't. It either needed fixing or it didn't. It just, to me, was the most pure form of the art of medicine. So yeah, I was just hooked.
A pattern I constantly see in my clinic is that people blame their pain on the final movement they made. Lifting something, twisting, slipping awkwardly. But the truth is, the body was already inflamed and stressed long before that moment. When you reduce inflammatory load from food, everything settles, joints move better, muscles relax, and pain becomes more cooperative. The pain-free plate shows you 7 foods that support that process. You can grab your copy at bodycheck.co.uk. That's bodycheck.co.uk/pain-free-plate. Now, back to the show.
And then when I came down to London, it was because one of the guys up in Glasgow said, "Look, if you want," and I did get on the surgical rotation, but I got bullied and it was horrible. And by the general surgeons, actually. And so my love for orthopedics just grew after that, because I was like, well, these general surgeons and vasculators, they're all fucking assholes. And it was just awful bullying that I had. But then I was like, right, one of the guys who was really nice said to me, "Look, you're born here. You're born in one of the hospitals you just worked in. You went to your university that's only like a mile away from where you live. Your high school's only like 2 miles away. Like, you need to broaden your horizons. Go away and then come back with some experience. Go down to London and then come back, and then you can get onto the higher surgical rotation." And I was like, actually, that makes sense. So at the age of 25, I went down to London. And, I applied to so many places, like 40 different places, didn't get any interviews. 1 or 2 places did give me an interview, but I got rejected. They didn't have me. And then suddenly I'm at this place, and I was getting very down and depressed about it. I was like, oh, for fuck's sake. And then I get an interview at the Royal National Orthopaedic Hospital, which is the biggest, preeminent place for orthopedics. And I'm like, oh God, right. Yeah, I've been rejected so many times by now. And I go in, and there's like 40 guys. They all got double barrel names, signet rings. They've all been to private schools, public schools, all this kind of stuff. Hello, yes, that kind of thing. And I get called in first, and I'm like, oh, here we go. And I go in, and there's like 8, 9 people around this massive table. There's like 2 professors and stuff like that. And they go, why do you want to do orthopedic surgery? Why do you want to come and work here? And I said, no, that's what they said. They said, why do you want to work here? And I said, well, this is the Royal National Orthopaedic Hospital. And no, sorry. They said, why should we give you the job? That's the question. Sorry. Why should we give you the job? There's 40 other candidates next door. Why should we give you and I said, this is the Royal National Orthopaedic Hospital. And at that point, some of them were like just making notes, and they all just dropped their pens and looked up at me. And the professor went, we know that. We work here. And I was like, I know, but the key word in that is national. And the guy went, what do you mean by that? And I went, well, all those guys next door are English, and I'm the only Scot. So by definition, you need to give me the job. And at this point, they all just burst out laughing. And I was like, and the professor goes, all right, fine, you've got the job. It was literally that. 1 question, 1 answer, and I got the job. And then he said, what department do you want to work in? And I was like, well, I'd love to work for you, Professor, but, I know that's very competitive and it's unlikely that I'll get that. So the next one, foot and ankle with John Angel. I mean, just put a name out there. And I knew it wasn't that competitive foot and ankle. So if I say that, it's more likely that I'll get it. And they went, great, fantastic, off you go. So then I walked past the room with all the people in it. And it was like, I'd only been in that interview room for like less than a minute. And I remember going like that. And they're like, they were all very competitive. No one was talking to me. And like, they're all like, you could smell the sweat and the anxiety and the stress. And they all just looked at me like, what the fuck? Why are you so happy? Why did you just walk out? Literally, like the moment you walked in, you walked back out again. Like, what is going on here? Anyway, so then I did work for John Angel and Dushan Singh, and that was foot and ankle surgery. And it was just so much fun. I love the fact you're sitting down. I love the fact that you're not having to lift some heavy leg up in the air or turn someone's back, like to operate on them. You're just sitting at the end of the foot, and there's so many different types of operations. There's operations on tendons, nerves, and ligaments, bones, joints, muscles, you name it. It's varied. And I'll give you an example. As a consultant orthopedic surgeon for like 10 years, at no point, and I was doing 2-3 lists a week, never, ever during that period, did I have 2 lists, consecutive lists that were identical. It was always different. Anything from ankle replacements to ankle fusions to Achilles tendon surgery, Achilles tendon repair, gastroc releases, Morton's neuroma, tarsal tunnel syndrome, midfoot arthritis, keyhole surgery in the ankle, cartilage repair, you name it. It's like there's literally like 100 different operations you can do. And if you compare that, for example, to a knee and hip surgeon, what does a knee surgeon do? Well, it's a knee replacement or knee arthroscopy, knee replacement, knee arthroscopy. If you're a sports knee surgeon, it's ACL, meniscectomy, meniscal repair, ACL, meniscectomy. If you're a hip surgeon, hip replacement, hip injection, hip replacement. So their list would be like 4 hip replacements in a row, back to back, every day, every week. And I think if your nature is you like something that's predictable, you like reproducible, you don't like change, you like steady, that will suit your personality. I'm completely different. I love change. I love variety. I love being pushed and being put into positions that are uncomfortable because that's where I know I'm going to learn and grow. So, I think that's why I gravitated towards foot and ankle surgery. Does that answer everything?
Yeah, definitely. I mean, I feel very much the same. That I love the fact that my job is so varied. One of the things I love about, not just seeing clients, but doing podcasting and also teaching professionals just keeps my work very, very varied, and if I was doing the same thing day in, day out, when I think back to the 1990s, I was working as a personal trainer. It was just like a treadmill, and it can get very boring very quickly. And you can fall out of love with it. But if you've got that variety, then, it's just really, really enjoyable. One of the things I know that you're quite proud of as well is the fact that your surgery rate was actually quite low, which, to some people might think, what do you mean your surgery rate is low? You're a surgeon. Surely, your job is to do surgery. But, there's the old saying, if the only tool you've got is a hammer, everything looks like a nail, right? And, I've heard many stories of people coming to me who went to see an orthopaedic surgeon, and what do they offer first off the bat? Oh, you need surgery. And, when I look back at their original case, it's like, oh, if you'd have come to me first, I would have definitely suggested a lot of things you could have tried before going down that route. So why do you think that your surgery rate was so low? And perhaps even describe what that means to the audience if someone maybe hasn't come across that term before.
So the term is conversion rate. So if you see 100 people come through your door, how many of those end up with an operation? So that's conversion rate. And So basically, I had some really great bosses when I was a junior. And I remember one of my bosses saying to me, you know, the key to being a very good and successful surgeon is um, learning when to operate, with which operation, for which condition, at the right time, on the right patient. And if you don't have all of them, it's not going to work. So you could have the right operation for the right condition at the right time with the wrong patient, and there's a problem. Does that make sense?
Yeah.
Or you could have the wrong operation for the right condition, for the right patient at the right time, and you got a problem. Like everything has to line up. And I remember another boss saying, you'll find that initially you want to operate on everything, but as time goes by, you'll learn when not to operate. And that's really important as well. Okay. And there was lots of different reasons why conversion rates are different. So for example, in the NHS, a lot of your patients will have been to the GP, then gone to the MSK service, seen a physio, seen a podiatrist, and they've exhausted pretty much everything. Then they come to you, and what the hospital wanted you to do is just simply operate on them, because that generates revenue. And I'm talking about the NHS. People don't understand this. But in the NHS, every patient interaction is coded, whether it's a clinic, outpatient, new follow-up, operation, procedure. Everything is billable. Everything is billed. People don't understand that, but it is. That's how the hospital makes money. And what the hospital wanted is just high yield operations. So they want everybody processed, and by the time they come to you, you should really just be putting them on the waiting list. And it's very easy when it's things like hip arthritis. So you got hip arthritis, it's, severely impacting their quality of life. They come and see you. Honestly, you've only got a hip replacement to offer them. And that's a very good operation for someone who's got severe hip arthritis. So you might have a hip surgeon whose conversion rate is actually quite high. It's like 80%, 90%, because there's an x-ray, the joint's painful, they get a hip replacement. Now, sometimes it might not, because it turns around that the patient's actually got other issues and other complications. They're not a good surgical candidate. Yes, they've got a bit of arthritis in their hip, but actually they might have a trochanteric bursitis, or they might have some inguinal hernia. So, it's never going to, it's not 100%. It's like, but it's high, because same with knee arthritis, stuff like that. So that's why conversion rates can be quite high in some cases, because you're being filtered. Now, what I found was, because foot and ankle is so complex and so varied, the diagnosis was oftentimes quite off the mark. And the reason why these patients hadn't had any progress out in the community was because someone had given the patient a diagnosis, a GP or MSK physiotherapist, and then that sticks. The patient owns the diagnosis. They don't want to let go of it because they're in pain. No one's been taking them seriously. Then someone says, this is why you're in pain. Well, they're going to keep hold of that. Like, they're not going to relinquish that. So they're holding on to their diagnosis. The next clinician holds on to the everybody reinforces that diagnosis. And guess what? Everybody's treating that diagnosis, and it's the wrong diagnosis. So you get all the right treatment for that condition, but you don't have it. So guess what? The patient doesn't make any progress. So what I found was, it was very dangerous to just assume the patient had that. So I, for example, would get a patient come through. This patient has a Morton's neuroma. Please, can you put them on the waiting list to excise their Morton's neuroma? Right? Now, number one, I don't actually believe that you should be cutting out this Morton's neuroma in the vast majority of people, because the nerve is being irritated, and cutting it out is a pretty drastic thing to do. Like, what the heck? Okay, so yeah, I'm not a fan of that operation. But oftentimes I'd be like, in the vast majority of cases, I'd be like, you don't have Morton's neuroma. Like, your bones hurt everywhere. Your joint hurts everywhere. Like, why do you think me taking this nerve out is going to change anything? Everything is still going to hurt. You're hurting because of this. And they'd be like, oh, and the hospital didn't like that, because I'd send the patients away for another test to confirm what I'm thinking. I would then bring them back to discuss it. I'd try a different treatment plan. Then I'd bring them back. And they're like, what are you doing? Like, you should just be putting this patient on the waiting list and operating on them. Well, what the hell are you, what's going on here? Why is your conversion rate so low? And I was like, well, because most of these people haven't got the diagnosis they've been told, right? It's actually something else. And actually, I'm not just going to do an operation because someone else has told me to do it. And maybe they don't need an operation. And then what I also found was as I turned my own health around, lost weight, reversed my type 2 diabetes, my hypertension, improved my sleep, my mental health. Guess what? All these aches and pains started going away. And I started sharing this knowledge with my patients. So guess what? They started feeling better. So guess what? Their aches and pains started going away. So then they didn't need surgery. And simple advice on footwear and stuff like that was enough, right?
Mm-hmm.
And I was doing the same in the private sector. And I used to say to my patients this, I'm like a really good surgeon, but a really shit businessman. Because if I was a clever businessman, I would just operate on you. You want the surgery. Your insurance company has said, go ahead and do it. I could just go ahead and do it. Nobody would be the wiser. But I know this is not right for you. I know we can fix this without having to go down the surgery. And believe it or not, like the one time I would get a complaint in the year was the patient who would get upset that I didn't operate on them because they wanted a quick fix.
Mm.
And here I am saying, no, optimize your sleep and your diet and your this and your that. And they'd be like, what the fuck? And like, just operate on me. Just, what are you? And they would complain that Dr. Malik is refusing to operate on me. Like, yeah. But so that's the kind of complaints I had to deal with. People upset that I wasn't operating on them, which I guess is a really good sign that I didn't operate on them. Can you imagine if something had gone wrong? And so like, yeah, so my conversion rate went from about 25, 30% to under 10%. But I was happy with that. Because like, I think an operation is a great thing for a person who needs it at the right time for the right condition, but you should avoid an operation whenever possible. So I've had surgeries, I've had carpal tunnel decompressions, and now that I know what I know how I could have avoided it, but I had type 2 diabetes and blah, blah, blah. My thyroid was shit. That's why I got carpal tunnel syndrome, okay? I had cauda equina syndrome, but that was because I was in a car crash. Someone slammed into the back of me. I needed surgery for that. I needed that.
Yeah.
Okay? But I've just had 2 disc prolapses in my neck this year. I was very close to an injection and surgery. I was very close, but I managed to avoid it and I managed to heal myself. So like I said, if you can avoid it, great. When it's necessary, okay. But you don't want to operate on everyone. Now, the problem is, in the NHS, doctors are incentivized to just operate on everybody. Okay? They just financially, surgeons like operating. The managers want it. They want you to have a low new to follow-up ratio. They just want you to just put the patient on the waiting list and just operate on them. In the private sector, it's no different. Private hospitals want a surgeon who's productive, making lots of money, operating on a lot of people. Surgeons want that because that's where they generate their money. The insurance companies have frozen and now actually start to reduce how much they pay surgeons and doctors for clinical appointments. So to reimburse and recoup the loss in revenue and the stagnation of revenue, they operate on more people because operations earn more money generally than consultations. So you have this perverse incentive now where surgeons are operating on more people because it pays the bills. It makes it worthwhile because having, a private practice is expensive. There are significant overheads. So you need to make about £50,000-60,000 just to break even. Because by the time you've paid your £30,000 in indemnity, your £30,000 in your secretary, then your room hire, your room rental, your dictation cost, your, all that kind of stuff, equipment hire, you're up to like 60, 70, 80 grand just to break even.
Yeah.
So you need to make a lot of money to make it worthwhile. Because remember, whatever you make, you need to pay those expenses, pay your tax, and then you get left whatever's left. So you could have a doctor that's on £150,000 and it sounds amazing. And, I don't want it to sound like, it's not a lot, but it is a lot. But they don't take home £150,000. They'll be lucky if they take home £50,000. And some people will be listening and going, that's a lot. Yes, it is a lot. But I'm just trying to explain that your surgeon isn't earning as much as you might think, the big bucks. Like very few are. And to make that money, they have to work very hard, very long hours, in evenings, because if a lot of them are working in the NHS and they don't want to leave the cult, right? They're bonded to the cult. So if they're going to do any work, it's going to be in the evenings and the weekends, which, I thought was ridiculous because, you're putting that stress on the body in the evening, spiking their cortisol. It's totally out of the circadian rhythm. It's just nonsense. And people are tired. That surgeon is tired. The team is tired. All that kind of stuff. Anyway, so that's just a little insight into surgical conversions and the kind of like perverse incentives.
Every week, I meet people who've been told their pain is just aging, just wear and tear, or something they just have to live with. And almost always, there's a deeper cause that's been missed. Gut stress, emotional load, sleep disruption, food sensitivities, poor breathing patterns, movement imbalances. And when we look at everything together, the picture becomes clear. If you feel something important has been overlooked, book a discovery call with me at bodycheck.co.uk/consultation. That's bodycheck.co.uk/consultation. All right, back to the episode. Yeah, it's interesting, if I've been working with a client and, they go and see an orthopaedic surgeon, and oftentimes they do come back and the surgeon says, look, I don't think surgery is the right option for you right now. Keep doing what you're doing. And I normally say to the client, that's probably a sign of a good orthopedic surgeon, that they haven't just said, oh yeah, let's book you in and we'll operate on you. They actually say, oh, you're doing other stuff. You're working on your nutrition and your exercise. Great. Just keep doing that. If things aren't better in 6 months, then maybe come back, So that always gives me trust that, I make a note of who that orthopedic surgeon is. And I think, well, if I get another client and I feel I might think they should see an orthopedic surgeon, then maybe they're the person I'm going to send them to, rather than someone, I mean, normally I get people coming in to see me and they've already seen the orthopedic surgeon and it didn't help, and sometimes made it worse. And it frustrates me. I kind of think, oh, if you'd have come and seen me first, I might have helped you avoid the surgery in the first place.
Yeah.
But yeah, that's a bit sad. So you've mentioned quite a few of the conditions that you used to work with in the foot and ankle. What were some of the most common ones that you worked with? And what would you say, in your opinion, were the common causes of each of those conditions?
So I saw a lot of sports injuries and saw a lot of ankle sprains. That's just a lot of the time, like, that is bad luck, right? So I had ruptured of two of my lateral ligaments last year. That was jiu-jitsu. Someone very recklessly picked up my ankle and just yanked it, and it literally went pop, like loud. Like, everybody in the gym heard it. Was like, "What's that?" I was like, "That's my ankle." I couldn't have done anything about that. But there are some people who get, and like, for example, you're playing football, right? Someone tackles you and then your ankle rolls over, and like, these kind of things. These are traumatic injuries, and you can't really avoid that, if that makes sense. Some people were just training badly. So what I mean by that is, like, you got a runner and you ask them, tell me about your exercise throughout the week. And they go, oh, I do a 5K run on a Monday, and I do a 5K run on a Thursday, then I do a 10K run on the weekend. And I'm like, okay, great. Anything else? I'm like, wow, isn't that enough? And I'm like, yeah, I know, but do you do any other form of exercise? They're like, I just told you. And I'm like, well, would you agree that an apple is good for you? And they'd be like, yes. And I said, well, if I have an apple for breakfast, lunch, and dinner 7 days a week, 2 in a weekend, do you think that's healthy? And they'd be like, no, I see where you're going with this. And I'd be like, yeah, exercise should be a balanced exercise, a diet of balanced exercise, just like, your diet that you eat. And they were like, huh. I was like, yeah, you need to do a bit of strength conditioning, aerobic work, anaerobic work, your endurance, your stretching, your mobility, your core, your sense of proprioception, all this kind of stuff. You need to mix it all in. And then they'd be like, oh. And I'd get these, like, runners were like my biggest group that would come to me. I love runners, otherwise, I'd be a very poor surgeon at the time. It was just great because like they were running for their mental health, and all they would do is run, and their weakness was so evident so easily. So, for example, you'd say stand on one leg, and their balance was all over the place, and their glutes were really weak. I'd be like, go up on your tiptoes, and they could just do it with 2 feet. I'd be like, do one leg now, one-legged tiptoes. Oh, and they'd be all over the place, and they'd have super tight calf muscles and everything. And I'd be like, look, you're compensating, and because your compensations, you're causing contractures and weaknesses elsewhere. Then you end up with deformities, and this also predisposes you to injuries and running injuries, and all this kind of stuff, and runner's knee, and jogger's knee, and all the plantar fasciitis, or whatever it is. And so that was, I'm just telling you about like some of the injuries and the ankle sprains and blah blah blah. But I loved ankle sprains because I would treat them non-operatively, but someone who had recurrent ankle instability with then stretched out ligaments, and you could feel it when you examine them, and also on the MRI scan you could see it. So their ligament, instead of being short and thick, was long and wavy because it's lax. So the ligament should be nice and tight, and what it does is it doesn't stop movement, it limits the movement. So it takes you to an end range after which it won't go further. That's the whole point with the stability. So the ligaments don't prevent movement, and there's an ulnar collateral ligament in the thumb, but it stops my thumb bending all the way back to my forearm. Okay. And that's why but if the ligament was wavy and shot to pieces, like and baggy, then they were always going to have instability, no matter what amount of physio and blah blah. And these people had typically had severe ankle sprains like 3-4 times, hadn't treated it properly, hadn't managed it, so now they are where they are. So the surgery would involve making incision and literally double breasting and tightening the ligament again, and I would get great results. I'd get people back doing sports and stable ankle and change their life. And, they message me going, look at me, I'm on the top of a mountain. Thank you so much. I'm back playing football, so I'm running again. So, that was nice. So I really liked that kind of surgery.
Did you ever use prolotherapy for that kind of injury?
No. So I had seen that in my fellowship, and I'm not a believer in it. So that's about injecting saline around the tendon and getting rid of the blood, neovascularization, and around the tendon I didn't see any successful results. Then sometimes people would put a low dose of steroid in it as well, make sure they didn't do it in the actual tendon but around the tendon sheath, and again, not a fan of it. I just didn't see very good results. So I'm not a fan of PRP injections, prolotherapy, steroids. Like, no. I mean, if you're going to treat these things, musculoskeletal, definitely, strengthening, looking at your exercise program, looking at your stress, acupuncture, blah, blah, blah. But the thing is, honestly, once you have a structural deformity, none of this other stuff is going to help. If your ligament is weak, thin, attenuated, and lax, it ain't going to just tighten up. It just doesn't happen. Same with an Achilles tendon. If it's ruptured and you've missed it, and now it's lengthened, healed in a lengthened position, you got a floppy foot. Nothing is going to fix that other than surgery. So this is why then I would do the 5 to 10% of operations.
Yeah.
Because all this other stuff ain't going to touch it. So there's a role for surgery and there's a role for other stuff, but yeah, I'm not a fan of prolotherapy. The other thing as well is doctors and radiologists were making a lot of money from these injections. And you have to understand the power of placebo. So, if you do an intervention and you say it's really expensive and it's really fancy and it's cutting edge, a significant number of people will feel some benefit from it. But it's placebo. And I have to ask myself, is this genuinely working? And I maybe have a skewed opinion because I would see a lot of people who had it and they said it had worked. Can I now do it? So, and it wasn't just prolotherapy, there's lots of other things, steroid injection, their plantar fascia or whatever. Oh, doctor, I've had this twice and it worked. Can you do it now? And I'd be like, if it worked, why do you need me to do it? And then they'd be like, but it did work. And I was like, and now it's not working. I went, did it work then? I guess not. So temporary relief, that's not a cure. That doesn't mean it's worked. Does that make sense?
Yeah. 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 My experience with foot and ankle injuries, conditions, is almost entirely due to the same, let's call it muscular imbalance, or imbalances, I should say, that creates an overpronation pattern when they're walking, running, etc. And that's putting excessive stress through normally like the medial side of the foot and ankle, or the shin, even the knee. What I've seen is a lot of knee injuries is because someone can't control pronation, so they go into overpronation. Things like bunions and hallux valgus as well, where obviously the foot is over rolling inwards, creating that excessive stress. And I'm not going to say that's the cause of every lower limb injury, but in my experience, that certainly forms the cause for most conditions.
Yeah.
Would you agree?
Yeah. So I'm going to share my screen if that's all right.
Yeah.
Can I share my screen?
Yeah. Yeah.
Can you see this?
Yep.
What can you see?
I can see form follows function.
Yeah.
Understanding.
So I gave this talk for Caroline Clark on Saturday, and I've actually published it on my podcast. It's let me just see where it is. So I did published it on my podcast as a bonus, and it's between episodes. Let me just tell you, 408, 407, 408, I think, something like that. I don't know. Anyway, so basically, I talk about form follows function, and how posture is everything. But look at this. It's talking about the kinetic chain. So if you pronate your foot, you get internal rotation of that lower limb, you get a valgus deformity at the knee. This creates pelvic tilt, but it's not just that. That hip abduction and pelvic asymmetry then creates thoracic and lumbar scoliosis, your shoulder dips, everything. So everything is linked. You cannot just treat the foot. So, and that's, when I used to see people with the foot problem, I would say, look, I want to see the whole body. We need to see everything. And I think it's just, if it doesn't look like a foot, it's not going to work like a foot. And this isn't an isolated problem. This is going to impact the whole kinetic chain.
Yeah.
So that's what my talk, Form Follows Function, was about. I think, people should check it out. It's quite good. It was very well received. It's very well received. Yes, it's between episodes 407 and 408. Yeah.
Yeah. Yeah. I don't know if you remember when I came on your show, it was about 18 months ago. I shared with you the CHEP totem pole.
Yeah.
Let me see if I can get that up on the screen.
It's really good.
Okay, you see that?
Yeah.
So obviously, the foot and ankle is down the bottom here.
Yeah.
On the totem pole.
Yeah.
So the bottom bit is classed as the slave joints, which is the spine below the level of C3, which is up here, the arms and the legs. And in the CHEP system, or the CHEP totem pole, each segment of the totem pole represents a system in the body. And the higher on the totem pole, the more important that is for human survival. So the body will protect any system higher up in order to survive. So at the top is the psyche, because, if you wanted to end your life, you could, right? So if any of these systems are out of balance, they're going to compensate lower down. So like you were saying in your diagram, if there's an issue down here because you've got medial rotational instability at the hip, the next question is, well, what's causing that medial rotational instability at the hip? It could be there's an anterior rotation of the ilium here. And you might say, well, what's causing that? Well, that could potentially be to do with an organ. It could be to do with there's a rotation or subluxation in the upper cervical spine, which is rotating the spinal cord. And then you can say, right, what's causing that? It could be they've got a hearing issue in one ear, and that's causing them to rotate the neck to try and hear. A similar issue with their eyesight. It could be that they've got jaw misalignment. And so when you said you want to look at the whole body, there it is, right? So the question always is, what's causing it in the first place? What's the root cause of the problem? And you can go really deep, and obviously that's what we do as check practitioners. And I've had things like knee issues tracked right the way back to a misalignment of the jaw. But ultimately, that's led to the medial rotational instability at the hip. You've got the adduction at the knee, putting stress through that medial side. But it's quite fascinating when you start looking at the human body at that level. And it can even be, it could be the psyche as well.
I was going to say, you know what? I found it goes even deeper. You really need to look at things like childhood trauma and stress and all that kind of stuff. So I think that's all linked. All of it is linked.
So one of the assessments we do in a check assessment is to get someone standing on 2 sets of weighing scales, so 1 foot on each scale, and you get to see how balanced they are. Now, there's different things that can cause an imbalance, but what we're really looking for is to see if the atlas is in alignment, because if the atlas is rotated, so it's rotated to the right, it will tend to put more body weight through the right side of the body. So if you're riding a bike and you lean to the right, what does the bike do? It's going to turn you to the right. And the atlas is kind of similar to that. So when someone's on 2 weighing scales, obviously you've got to think about other things, like if they've got pain or previous pain in one leg, well, they're going to probably try and put the weight on the good leg, right? So you got to weigh up all these things. But I remember hearing about this was on a check course. I wasn't in the class. This was in San Diego, and there was a guy in the class, and Paul Check was teaching the class. And he got this guy to stand on 2 sets of weighing scales. And this guy was 11 kilos heavier on one side. And so
That's
Paul
a lot.
said, yeah. I had a guy yesterday, 10 kilos heavier on one side. I've had people with 20 plus kilos heavier on one side.
Wow.
Yeah.
I've never seen that. So I used to have a gait scan. Well, I still do. And so I would scan them. And one of the things you do is you see the weight distribution through the feet. And, I say about 50% of the time there's a bit of asymmetry, but it wasn't that much. It was like, it wasn't a huge difference. But yeah, some people would favor another side more than another, especially if they had pain in that foot, especially if they had some issue, but I mean, the 10 kilograms is a lot.
Yeah.
That's massive. Are your weighing scales properly calibrated?
Yeah. So anyway, going back to the story of Paul Check with this guy. So I think Paul Check paid about $5,000 for his scales. So they were good scales. And so he's measured him. He's 11 kilos heavier on one leg. He gets him to lie on the treatment table, and Paul starts palpating his reflexology points on his foot, right? And he's assessing what's going on internally. And so there's obviously other students in the class are watching this. And Paul stops and he says, "Someone close to you died recently?" And the guy says, No. Paul's like, "Oh, okay." Carries on assessing this guy's foot. Stops again and he says, "There's someone you know has died recently. Who is it?" And this guy's like, No one, right? So he keeps kind of massaging the foot. And he stops and he says, "Who's died? Someone close to you has died recently." And this guy went, "My best friend died a few weeks ago." He'd forgot his best friend had died. Obviously, this, it's traumatic, right? And so Paul starts treating the base of his foot, and this guy starts crying, right? As you can imagine. So basically, Paul's relieving grief from this guy's body. I'm guessing he was probably on the lung meridian, I'm guessing. Because obviously the lung is where you tend to store grief. So this guy is crying like a baby, you know, felt really embarrassed in front of his classmates, you know. I won't give it away who it was. Anyway, so this guy's in bits, and Paul wants to carry on with the class. And where the institute used to be, there was a big, I think it was an oak tree out the front. And he said, look, I want you to calm yourself down. Just go over to the tree and just hug the tree. And this guy was not that way inclined, and he was very left brain, very scientific. And he's like, what the hell? And he was in such a mess. He was like, oh, yeah, whatever. And he later said to another classmate, he said, I went over to the tree. I put my arms around the tree. And within a few seconds, my friend appeared in front of me, the one who died. And he said, I'll keep going to say his name, but I mustn't say his name. He said, look, I'm absolutely fine. Don't worry about me. Where I am is great. Like, it's amazing here, right? You shouldn't worry about me. You know, don't feel, you know, that you've lost because I'm in a really great place. He walks back into the class and Paul says, right, can you get back on the scales? He stands on the scales and they're bang level.
There you go.
Right? Which kind of shows you how complex the human body can be. Although I always say, oftentimes the solutions can be really simple as well. But I had another guy on the podcast, a good friend of mine, Rob Brinded. He used to work for Chelsea Football Club. And he had a similar experience with a player. And you'll find this quite funny, probably. He had the whole medical team watching him. And he got this player to stand on weighing scales. I think he said he was 7 kilos out. And he said to the footballer in front of the medical team, including the team doctor, he said, I want you to think about the best sex you've ever had. Right? And my friend points to the dial on the scales to the rest of the medical team. And he says, right, are you thinking about the best sex you ever had? And he's like, yeah. The scales were bang level, right? Then he said, I want you to think of the most stressful moment you've ever had in your life. And he's pointing to the display on the scales to the medical team. And he's like, right, are you thinking about it? He said, yeah. He was now 8 kilos heavier, right? And he said the medical team, it just went right, that they just didn't even acknowledge what had happened, you know? But that just shows the power of the psyche over the physical body.
Absolutely.
Which I find, you know, absolutely fascinating.
I always told people stress isn't a mental state. It has physical manifestations. And it's interesting what you said about that person saying they're in a good place. Do you know, I've said so many times that death is such a psyop. Like we're hardwired into being terrified about death. And like, oh my God, the finality of it. Oh my God, what's on the other side? Oh my God. And the truth is, if people actually knew how great it is on the other side, everybody would be checking out of this existence. Like early, they'd be like, why am I paying my taxes? Why am I putting up with this? So like, I'm off. I'm not hanging around. So to keep people in this state, because whatever this state is, you have to fear what's on the other side of the curtain. But if you pulled it back, you'd be like, what are we scared of? That's what I think. Are you scared of death?
I don't think so. It does make you wonder. I think the only thing I think is, would I miss maybe some of the people I'd leave behind and animals? But no, I don't. What's the saying? Energy can never be destroyed, only transformed. That's kind of how I see life. I don't feel like, you know, when we leave this body, you know, our soul or whatever you want to call it, I don't think it is gone. I think it's just on another plane.
Absolutely.
It goes to a non-physical plane. And I do believe that at some point that soul will enter another body and be in the material realm again at some point.
So you believe in reincarnation?
Yeah. You are not broken. Pain isn't a punishment, it's communication. One of the clearest messages your body sends is through inflammation. When you nourish yourself in a way that supports your gut and immune system, pain naturally becomes easier to manage. The pain-free plate shows you 7 foods that help bring your body back towards balance. And you can download it for free at bodycheck.co.uk/pain-free-plate. Now, let's get back into the conversation.
Yeah, I don't know. I'm open to it.
Well,
I mean, who knows? Who knows?
I'll tell you a quick story. So I don't know if I've said this before on my podcast. One of my nephews, when he was 3, was in my mother's kitchen. This was he's actually, I won't say his age. This would have been 36 years ago, and I think my mum was cooking, and he said to my mum, "What happened to your little yellow car?" And my mum said, "What little yellow car?" He said, "Yeah, you used to have a little yellow car. What happened to it?" Mum said, "I've never had a little yellow car." And he's like, "Yes, you did. Yes, you did. You used to have a little yellow Honda with a black roof." And my mum went, "Oh my God, who told you that?" He went, "No one." And she said, "Well, how do you know I had a little yellow Honda with a black roof?" He said, "Because I used to watch you when I was up there, and you used to park it down there." So there used to be a row of garages around the back of my parents' house. And my mum used to park it at number 1, which was, right at the end. And this was about 30 years before he was born,
Oh wow!
right? How do you explain that? And then there's
What? So her son is some random neighbor they used to watch her. That's insane.
well, he was saying, "I used to watch you when I was up there."
Oh, up there, as in not upstairs in the house, but upstairs in the wherever it is.
Yeah.
Oh, I thought you meant upstairs in like upstairs window
No, he
somewhere.
wasn't even born.
Oh wow!
It
I
was like
thought,
30 years before he was born that she had that car.
wow, that's a bit insane.
Yeah. I mean, the book's by Brian Weiss. I don't know if you know Brian Weiss.
No, who's that?
His books were amazing.
How do you spell his surname?
Weiss.
Brian Weiss.
Yeah. Many Lives, Many Masters was his first book. And after I read that one cover to cover in like a day and a half, I ended up reading all of his books. Fascinating.
Ah.
And then there's loads of stories about, little children saying, I want my real mummy and daddy. And they're like, "We are your real mummy and daddy." No, 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 no. Not, "I want so-and-so and so-and-so." And it turns out they end up finding this other family. And he says things to them that there's only one way he would have known that he was actually their, their son or daughter in a previous life. It's a fascinating subject. So we're going a little bit off.
It's fascinating.
Topic, but
I know part of me, the old self, is like, this just sounds fucking crazy. But part of me, the new self, is like, man, anything's possible. Anything's possible. Don't discount anything. So
I question absolutely everything, and when I hear things now, I don't just accept them. I'm still questioning new stuff.
Do you know where I like to be? I like to be in a position where I'm open to everything, but I question everything.
Yeah.
And I'm not fixed to anything.
That's exactly where I feel I am.
Yeah. Because when you get fixed to something, you're just like...
Yeah, I mean, I watched Stu Peters' documentary called Occupied.
Oh, yeah, what's that like?
Oh, you need to watch it.
Really?
Yeah.
I've heard different things about him, and like, he's just an agent as well.
There's things in there you would definitely agree with.
Where can you find it?
I'll tell you afterwards. It's on his website.
All right. Is it free to watch?
It's free to watch.
Oh, okay.
But there's things in there that will challenge people greatly.
Really?
I mean, and I watched it and I thought, I'm just going to keep an open mind. I'm not going to make a decision to go, "Oh, that's all nonsense," because everything I've been told before. But then at the same time, it might just be propaganda, right? You've got to be aware of that. But yeah, fascinating, absolutely fascinating.
Yeah. So, what I was going to say, what do you think of flat Earth?
It's funny because remember I was with you the other week when someone asked you about that. Do you remember?
Yeah. People
I
ask me all the time, what do you think of
Yeah,
it?
I haven't really looked into it. So I would say I'm open to new information. And I would say I honestly don't know. And I wouldn't turn around and say I think it's all nonsense because I haven't looked into it. So how do I know? I think it's very easy for people to have a belief system, and then when they're shown something that challenges that belief system, they say, "Oh, that's all nonsense." But actually, for me, it's like, well, surely you should look into it before you can say that it's nonsense, right?
Yeah. Yeah.
I'm open to it. I don't know, honestly, don't know. Um, when I've been on ferries crossing the English Channel, it looks like it's round. Like if you look at the sea line, it looks round to me. Does that mean it's the Earth's spherical shaped? Maybe, maybe not. You know, um, you, I think we've been lied to in so many ways. I think things that you definitely believe are true, you've got to leave at least a part of you open to the fact that that might be wrong.
Yeah.
Um,
Do you know what I'm thinking? I'm thinking these woolen socks I'm wearing are rubbish because my feet are freezing. My head is warm.
well,
My
we're talking
body's
about the
warm.
foot and ankle, so it's relevant to the conversation.
Man, it's so cold. So cold. It's unbelievable.
So,
Yeah.
um, so we've mentioned things like plantar fasciitis, Achilles tendinosis, ankle sprains, neuromas, bunions. Were there any particular pieces of advice that you gave people that you saw really help them, and and obviously potentially avoid surgery?
Yeah, I think the best things were improving your diet, your sleep, and fasting.
Mm,
They're huge. You lose the weight, you've got less pressure on your feet.
mm,
You sleep, that's when your body heals, you know. And fasting is so powerful. Promotes growth hormone and it's got so many other health benefits. So just improve those. I just found people did so well.
mm,
Um, and then your footwear as well. Just don't wear shoes that are too small and too cramped. You know, women wore stays and corsets for about 2 centuries, and I think now, and if you said to any women like wear a stay and corset, they would laugh at you like,
mm,
what kind of barbaric thing is this? You
mm,
know, um, and it's the same with shoes. You look at all these people wearing these pointy shoes, and everybody wears shoes that are too small. So they go, oh, I have to break into my shoe. No,
mm,
no. If you have to break into your shoe, there's only two things that's happening. One, your foot's getting now used to this uncomfortable position, or two, you're stretching the material of the shoe to fit your shoe. So, look at your foot shape and then draw a silhouette around a piece of paper, put it on a piece of paper and draw it. Then get your shoe and draw a silhouette and then match the two up and see if they fit. And if your foot is spilling out of the shoe, that shoe's not right for you.
mm,
And you have to get shoes like with at least a finger's width between the end of the toe and the end of the toe box. So like, just don't cramp your toes. And
mm,
I've discovered that Clark's is a con. People go, I go to Clark's for my kids' shoes. Their sizing is all off. Like literally, like within a few weeks, your kid's shoes are going to be too small, and it's a gimmick because then they just make you buy more shoes. Like
mm,
you need to wear shoes that are the right size and right shape. So we wear like foot shape type shoes. I got my Birkenstocks.
mhm,
Got my what what are my running shoes? I've gone what they are. They're like very broad, basically. And my wife has gone that way as well now. I've managed to like inspire her to do the same, and now her feet feel much better.
mm,
So, and I also walk around barefoot quite a lot, so I use the muscles in my foot. So if you don't use it, you lose it,
mm,
and you got lots of tiny little muscles in the foot. And actually, it's not just your foot; all these little tiny muscles. I talked about it in my presentation. It's in the podcast. All these tiny muscles are really important. They stabilize the joints,
mm,
and if you just work big muscle groups, quads, calf, pec, biceps, but you ignore all the fine motors, your glutes and, quadratus, your teres minor, teres major, your rotator cuff, your little lumbricals, whatever they might be, then you're going to end up with problems. You end up with the contractures, the toe deformities, the foot problems. So use all your muscles, work your feet, walk around barefoot. I exercise barefoot. I find it so much better for my balance and everything. And wear, shoes that actually look like a foot and are the right shape and size.
Yeah,
and that especially goes for women, because women don't like big feet. Like, they don't like the idea of having big shoes for big. They think petite is nicer. It's not a sexist comment. This is years of observation, by the way.
Yeah, I've been wearing 5-finger, like Vibram 5-finger shoes since about 2008. And when I first started wearing them, I had to wear them for like a few hours a day and then switch back into my trainers. And then eventually it was, like I'd do a whole day at work with them. And then eventually it would be all day. So to work, at work, and then home again. And I like, if I have to wear, like, if I'm going to some celebration or something, or a party, and I have to wear normal shoes, it just feels horrible. My tennis shoes, they're okay. They're not too bad. They've got quite a wide toe box. But it's not just, for me, it's not just about how much space your toes have. It's also the fact that when there's very little cushioning under your foot, obviously that you've got more proprioceptors at the base of your foot than most other areas of your entire body. If you look at the homunculus, right, your feet are massive, right? The more cushion you put underneath the foot, the more you're dumbing down the proprioception that you're getting from the ground. And I know there's been studies done with runners comparing running shoes to barefoot shoes, and the load that goes through the knee is massively higher. I can't remember the exact amount, but the load that goes through the knee, the stress that goes through the knee with each heel strike is massively higher than when they're wearing a barefoot shoe. And the thought is that the body has to land that much harder to get through the padding of the running shoe to feel the ground. So it's quite ironic that, running shoes have got padding underneath to soften the blow, and actually they do quite the opposite. And I know when Nike first come out with, I think it was the Nike Air running shoe, that physiotherapists in America, their income went through the roof because they were having so many more injuries to deal with when they first brought out the running shoe, which was quite interesting.
Yeah. Well, if you look at the normal fat pad of the foot, it's like that's where these running shoes have replicated. Do you know what I mean?
I know what the fat pad is. Yeah.
No, but what I'm trying to say is, like, these training shoes, all they've done is replicate what your body already does.
Right.
Which is kind of amazing. So see this?
Yeah.
This is what I mean. So, like, so you got this fat pad under the heel, you got fat pad underneath the forefoot, and if you actually look at it, it's little compartments of fat. There's little septae, fibrous septae in between, and it's like it's like this amazing cushioning system, and it absorbs shock and dissipates the forces. It's quite amazing, actually. But you're right, it's difficult. You can't go straight from, like, having your shoes that you've had all your life and then just suddenly go for this barefoot thing, because the transition might be so severe you end up just with injuries and stress fractures. You have to do it very gradually.
I found the flexor muscles in the base of my foot were really sore at the end of the day. Even when I first started, I was doing 4 hours a day. So I'd walk, so I'd commute to work wearing trainers. I'd put my 5-finger shoes on for the morning, and at lunchtime I'd change back into my trainers. So I was literally doing like 4 hours, and the muscles under my foot would ache. And then gradually, when I got used to that, I would wear them all day at work, but then I put my trainers back on to commute back home because they'd be sore by the end of the day. And then after, I can't remember how many months, I just began wearing them all the time. The other Saturday we walked quite a long way, didn't we? And I was wearing 5 fingers all day long. I didn't even think about it because, the muscles in my foot are now conditioned to be able to walk any distance.
Yeah. I won't be doing the same walk this year because I've just got my little kids on my own, and they will not want to walk that far. So I've told them we'll hang around for about 45 minutes to an hour, and then I'm gonna take them off somewhere and have somewhere.
Yeah, kids won't want to walk that far.
Yeah, I'll have lunch with them somewhere nice. That's the carrot. It's like, come with me. We'll just do a little bit, and then we'll go and have a nice lunch. They're like, okay, Daddy.
Yeah, that sounds good. Sounds good. This is a big topic. What's your view on orthotics?
I think there's a time and a place for them. 100% for sure. I think they're overused and badly used. So I think if you're a podiatrist and you're not doing any surgical intervention, the problem is over the years, I'm sorry, I've just seen it. If the only thing in your toolbox is a hammer, every problem looks like a nail. And then when you make a lot of money from it, and I knew podiatrists who were making double what an orthopedic surgeon makes. And it was a classic of, this is a special orthotic and it's been made in Canada and we've had it flown back. We created the mold and we shipped the mold to Canada and that's flown all the way back. Or I'd have like, it'd be like, or I've had this designed in Australia and now it's come. And the further out it was, like the more important, the more expensive that they could charge it. And it's like, by the time you got your consultation, the orthotic and follow-up, I mean, you're talking, some people are paying it £1,500. It's just insane. And there's very variable like quality, and a lot of these orthotics were made very cheap and the markup was huge. A lot of the orthotics were just not necessary, so almost everybody got told they overpronate. I cannot stand that diagnosis. You overpronate. What's over what? Like, everybody pronates. That's part of the normal gait cycle. Locks the midfoot joints so that you can propel forward. Yeah, we have to pronate. What does overpronate mean? And I learned this the hard way. I was a junior doctor. I was wanting to get into running. Someone recommended a running shop in Covent Garden. I went down there. They went, we got a treadmill and we will video you and we'll get the right shoe for you. I'm like, oh. I didn't know any better. I was like 25. I was like, great. Just when I came down to London. And so I get on this running thing and they're, you're overpronating. So I got this. I was like, overpronating? I'm like, oh, really? And they're like, yeah. Then you need these special anti-overpronating training shoes. So they had a very deep medial instep. I was like, all right. And then obviously they were more expensive. So I got them. Then I started running with them. I was like, God, these feel weird. Maybe I just have to keep running. So I kept running. Guess what? I got a stress fracture on my base of fifth metatarsal because I was supinating so much and overloading the lateral side because it's fucking overpointing. And you know what? Then I did all the research and learned about it while I'm in this stupid boot recovering from my fracture. And I was like, I do not overpronate. I do not have a high medial instep. I was perfectly fucking fine. I just need normal training shoes. And this person just fobbed me off and told me this crock of shit and sold me this expensive training shoe. And then when I was doing foot and ankle, oh God, the number of people go, oh yeah, I overpronate. And I'd be like, you don't. You really don't. You got pescators foot shape. You do the opposite. You're rolling out. And I saw so many people who would get orthotics and then run into trouble because of the orthotics. But then, look, on the flip side, I saw a lot of people who did really well with orthotics, had the low dome insole, took the pressure off the mortise neuroma. Yes, some people had an acquired flat foot and it was flexible, so a medial arch would support it. La da 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 da. I saw a lot of good stuff. I saw a lot of bad stuff. So it's not like there isn't a yes, no. It's a nuanced thing. And again, like surgery, right? If you have an orthopedic surgeon who is operating on everybody because they can, because it makes a lot of money, well, a lot of that was unnecessary surgery and you're going to leave a lot of people with pain and complications. But you will make a lot of people happy too, So that's why I think of orthotics. But anyway, I got so disillusioned with the quality of the orthotics and finding good people to refer to because, again, blanket statement, I'm not picking on podiatrists. Everybody, no matter what their discipline, doctors, surgeons, car mechanics, architects, engineers, electricians, plumbers, finding good people is freaking hard. Like the vast majority, like obviously, are average. A significant minority are really shit.
Mm.
And a very tall, small minority are excellent. So when you find the excellent, you hold on to them.
Mm.
And so I got quite fed up with the very mediocre and very bad podiatrists. And I thought, you know what, I'm going to do this myself. So I got a gait scan. I used the system for the orthotics. I would design it, and it was custom made, 3D printed. And it was only in the last few years of my career, but I must have made about 300 orthotics. And I think I had one patient who was not happy.
Mm.
So, I was quite happy with that. And I
Mm.
did not charge an extortionate rate. And actually what I would do is I would say to people, try this off the shelf orthotic first. It's like £20 on Google, whatever. I was like, look, if you feel an improvement with this, then great. That might be enough. If you're like, this is great, but it's not enough, like you've got, instead of a 90% improvement, you're like 50% improvement, you feel like it's doing something, but it's not powerful enough, we can then explore custom orthotics, and I can make that for you, but there's going to be more money.
Mm.
Does that make sense?
Yeah.
So, and that's what I would do. So it was like, yeah, that's what I was doing. And I wasn't charging £1,500,
Yeah.
nothing like that. Nothing like that.
Yeah. I get a little, I say, exasperated when people come in and they'll say, I was overpronating, so then I got an orthotic. Well, again, if you look at the check totem pole, what's causing the overpronation, and why don't we fix that? Right?
Exactly. And also, just it's a normal thing in your gait cycle. And the only time I think, an overpronation is a real issue is when it's new and it's an acquired or post-traumatic. And the things that are driving that are tibialis posterior tendon dysfunction at the level of the leg, or they've got a spring ligament tear and dysfunction, or it's driving higher up, like the knee is going into valgus, or the hip is doing, and then that's forcing the foot in. So it's either the foot driving everything up, or something from above driving the foot down. And you need to address those things. And so around the actual foot is tib post tendon, muscle dysfunction and tendon dysfunction, or spring ligament, and but there's other things that deal with it. So it was definitely a diagnosis that's bandied around too much. And I'm not picking on podiatrists, by the way. The thing is, osteopaths and physios were also getting into the game of orthotics, because they were like, oh, this is a nice little money earner. And like, put them in a gait scan and tell them, or a treadmill, and tell them to overpronate. And I don't think a lot of it was they want to make money from it, but that, where, if there's an incentive, there's going to be an outcome. I think a lot of people just wanted to be able to offer something extra. So I remember this physiotherapist who was doing ultrasound scans, was doing shockwave therapy, was doing orthotics, was doing physio. And the danger is you start becoming jack of all trades and master of none. And it's just like, how good are your ultrasound skills? And do you know what I mean? And it's just and I would speak to the physios, and they had the same problem as the surgeons. The insurance companies are paying them less, giving them less sessions. So now they're thinking, how can we recoup these costs, offering different services? It's just, it's a race to the bottom. It's just, this is the system.
Yeah. The other issue potentially with orthotics. So let's say someone's overpronating, they get an orthotic to prevent overpronation. So what it's doing is preventing that natural movement into pronation. Well, if it's coming from the hip, and from my experience, that's nearly always the case. So the hip is internally rotating excessively. You're now preventing the foot from pronating. Now you've got torque at the knee.
Yep.
Right. So if you want to end up with an anterior cruciate ligament sprain, right, get an orthotic to stop you overpronating.
Absolutely.
And again, I've had many cases where people have come to me and they've got an issue at the knee, and they say it started when I started wearing the orthotic in my shoe.
Yeah.
Dude,
But
Yeah.
I need to pee soon.
Okay.
Cool.
And
get on with other stuff. Just giving you a heads
awesome.
up.
Yeah, we've done kind of most of what I wanted to speak about today anyway.
How long are your average podcasts anyway?
About an hour.
Oh, well, this is 90 minutes.
Yeah, that's fine. Sometimes they go longer. That's fine. One more main question. So obviously you've seen, numerous numbers of the issues that we've been talking about today.
Yeah.
What do you wish more people knew so they could prevent foot and ankle problems in the first place, apart from not doing Brazilian Jiu-Jitsu?
To prevent foot and ankle problems?
Yeah.
I think just that, like what I just already mentioned, use your feet, walk around barefoot as much as possible, exercise barefoot, and wear shoes that are designed properly for your foot, not some aesthetic thing that you think is, I went to a wedding recently and all the guys were wearing these horrendous pointy shoes, for example. All the girls were wearing these pointy high heels and everybody's walking around. And I'm thinking, are you actually comfortable in those shoes? like, could you spend the whole day wearing those shoes? I doubt it. So we need to get away from this idea that we have to choose aesthetics over comfort. Just wear nice, comfortable shoes, That's what I think.
Yeah. And get barefoot as often as you can, especially on grass or sand, so you're grounding at the same time, right?
Absolutely.
Yeah. Awesome. What's next for you, Doc?
What do you mean?
You can answer that however you want.
I don't know yet.
I know you're working on a book, right?
Yes. I don't know. So I feel like every 7 to 10 years, if I look back at my life, I've kind of gone for another big chapter in my life and kind of reinvented myself.
Each of the chakras every 7 years, right?
Is that what it is?
Mm-hmm.
Seriously?
You've just passed. You're in the stage of becoming a teacher.
Yeah, I don't want to be a guru.
A wise man.
I don't want to be a guru, and
I don't have to be a guru.
I don't want to be a cult leader. Don't want to be any of that stuff. Send me the information about this chakra business.
Yeah.
But I just feel like every 7-10 years, I'm changing. And so I don't know where I'm going to be next. But all I know is it's going to be different again. I'm going to be doing something different in the next 5-10 years. Don't know what it is.
And how's your book writing coming on?
Not very good, which is what I need to go away and do.
You're meant to be off this month, right, to write the book?
I know, but this pesky person told me to get on his podcast.
It's my fault.
It's all your fault.
So could you leave the audience with where they can find out more about your information, your podcast, your Substack?
Yeah, really easy.
And also how they can consult with you. I know I've referred people to you for your consultation service as well.
Thank you for that. It's really simple. Just go to my website, docmalik.com, docmalik.com.
Awesome.
And I'll see you on Saturday.
You will see me on Saturday. And thanks a lot for your time today. And it's been great talking as always.
Thank you. I normally don't drink a coffee, which is why I need to pee so badly. But it was so cold in my office. I was like, I need a hot drink. Now I'm regretting it because my bladder's about to explode. But anyway, listen, thank you so much, Leigh. Really enjoyed this.
My pleasure. So that's it from Doc Malik and me for this week. But be sure to join me same time, same place next week on Beyond the Pain. Thanks for listening to Beyond the Pain. If this episode resonated, please follow the show, leave a review, or share it with someone you know who's been struggling. And remember, pain is not permanent. With the right insight and support, you can turn it into power. Until next time, stay open, stay strong, and keep moving beyond the pain.